When Medicare first, and specifically CMS and CMMI after the ACA, started coming out with the rules and regs involving ACOs, I thought there was going to be one big problem, and that's actually manifested itself. And that's the problem that ACOs were largely judged, and there are a couple different ACO models, they were largely judged on how well you were doing in the past, not how well you were doing up against other practices or ACOs or providers on a regional or national level. Why is that a problem? Let's take a simple example. Let's say that providing a type of care, you're providing it now at $100. So let's say your target is $90. And by reducing those costs by $10 for that type of procedure, you get to keep $5 and the government keeps $5. Well, what's your next target? It's somewhere less than $90, let's say $80. So there's a point that literally it goes to zero. So what we're seeing after a couple of years, we're seeing that practices can't go any further, or providers in an ACO, because they're already being efficient and they don't get any benefit for maintaining that efficiency. That's one of the big problems, and it's kind of interesting that the federal government has come out and basically said that, you know what, we have to change and we have to think about changing how we measure ACOs. Another is this. Think about that you went out, and I use this example a lot, if you go out to play golf, you have no idea what the yardage on the course is. You have no idea whether a hole is a par 3 or par 4 or par 5, and you basically have to hit the ball with a blindfold on. That's what's happening on the ACO side. And what I mean by that is you don't know typically going into it what the measurement is, what you have to do better, and therefore what you're going to get on the back end. In a lot of cases, you don't even know the patients who were assigned to that ACO because it happens after the fact and after the government basically quantifies the savings, or if you don't get savings, you have to actually pay money if you're in a risk ACO. So there are a lot of problems that need to be ironed out. And there have been a number of different groups, including up at Dartmouth, that have basically provided some analysis around this and specific recommendations of how making ACOs better. I think the ACO phenomena is, on the surface, it has some benefits. Right now, frankly, I think it's just consolidating healthcare. And I think the other problem is the savings that we have to date from ACOs is basically a little less than 1% of the total Medicare spend. So we don't have much of an impact yet at all.
The problem that most providers have, I think, with the ACO model is that their interests are not always aligned. Now, in many of those ACOs in development, the physicians engage the ACO entity as employees. That's one thing. But I think that there's a whole universe of arrangements between the ACO mothership and the practices that will provide, hopefully, high-value services to the ACO. And the rules of engagement have yet to be defined. And that's true on both ends, right? The ACO doesn't know how to deal with the oncologist, for example, and the oncologists don't know how to deal with the ACO. I think part of it, ironically, is sort of harkens back to the days when the practice had to deal with the hospital administrator, and those meetings weren't always so cordial, successful, collegial. We need to change that, obviously, because they need to be able to be pulling the oars in the same direction.
I think one of the benefits and the lessons that we're seeing out of ACOs is basically the need to and the ability to coordinate care. And what's nice about it is we've set up a system with the laws, including the Stark laws and antitrust and all of that, where providers can't communicate. So what's interesting here is, at least under the ACO, we've pulled some of those barriers down because now we believe it's important for different providers in different specialties in physician practices and hospitals to communicate and coordinate care and really focus more on that on that patient and not as a widget shuffled around with these different groups. So I think we've learned the importance of care coordination. What I'm concerned about on the ACO side is that it's been an excuse for large systems, and specifically large hospital systems, to become even larger. So to buy up physician practices, to buy up the referral network, to sort of consolidate more and more, as we've seen happening, for example, up in Connecticut with the Yale system. And I think the problem with that is that you necessarily, maybe you get some care coordination, but we actually see higher cost of care to the patient, to the payer, whether that payer be the private payer or Medicare, when we have consolidation. So I'm a little concerned that one of the lessons we've learned from the ACO side, which is care coordination, that's a good lesson, but I think that part of the unintended consequence that we're seeing is a consolidation of healthcare. I don't think that's healthy. It hasn't been shown to improve the quality of care. In some cases, it's actually increased the quality of care, and it's certainly increased the cost of care.
I would say the single most important lesson is the importance of data and analytics. So, and I happen to be a great fan of the concept of performance measurement and process improvement. And we have learned, and as a practicing physician for a long time, I actually knew this, that for the most part, hospital systems, now they want to be ACOs, have not really developed methodologies for understanding the concept of measurement and continuous quality improvement. That's not to say they haven't done it in certain things, like let's say the operating room, right? A lot of hospital systems have made operating room function very good. But on a more enterprise basis, the idea that you should be focusing on opportunities for improvement is something that I think, irrespective of whether ACOs ultimately succeed or don't succeed as a delivery model, the introduction of the concept of measurement and process improvement will actually improve healthcare.
One of the problems when you think about ACOs is actually specifically about cancer care. And why is that a problem? Because if you look in an area where the drug therapy piece, both the cost and the innovation of new drugs coming out, that can literally break the bank of the ACO. So how do you account for, especially when most ACOs on the government side, they are set up to basically you are judged against yourself, you can stifle innovation. What happens when an oncologist is a part of a practice who's in an ACO, a new drug comes out, the drug is clearly the standard of care, let's say one of the new PD-1s or something like that, and you want to give that, but the cost is higher, especially in terms of what came before, the problem is you're going to break the bank. So the rest of the ACO is going to look at you, and you're going to have all the pressure on the world in terms of not doing anything that increases costs, especially when you're judged of how you did historically. So there's a big disadvantage for oncology practices in the ACO side specifically. It's not like primary care where somebody comes in with a sore throat or a condition that's treated the same regardless. So I think we've got some more work to be done. The interesting thing is that because of the work oncology practices, and especially in the community setting, are doing on the oncology medical home, and sort of really getting their house in order, if you will, in terms of quality measures and measures of value and what they're doing and transforming the practice to be really patient-centric, that has the ability to actually broaden out into the neighborhood, the medical neighborhood, and add other specialties. One of my big problems is that we've defined ACOs by a payment model. We haven't defined ACOs as what is the process that's going to allow us to actually increase the quality of care and decrease costs. I think actually oncology practices, and specifically community oncology practices, can actually be the nucleus to build really novel, effective ACOs around.